All right, welcome back, guys. We're here for the next session. This one's going to be on the navicular fractures. You had a chance to see early on during the basketball session a navicular fracture that was shown, but this is going to spend a lot of time talking to experts who are pioneers in defining how this is treated. Bryan Hartog is going to moderate and lead us through this. I do want to thank Smith and Nephew for sponsoring this session. Thanks.
Thank you, Selene. Really appreciate all your efforts in putting this amazing program together. I've got a very distinguished faculty to help talk about this somewhat challenging issue of navicular fractures, both acute and chronic stress fractures. I'd like to introduce Dr. Alan Yan from the University of Pittsburgh Medical Center. He's been on faculty there since, I believe, 2017. He's had a big interest in navicular fractures and as it relates specifically to surgical anatomy and approaches, and also a 3D mapping, modeling, and surgical planning method that he's been helping to develop and research. And then to his left, or your right on the screen, is Dr. Jim Nunley. He's for many years was the chair at Duke University. Jim, are you emeritus now, or are you still practicing?
No, I still practice. Thank you very much, Bryan.
Jim has been, for decades, a leader in foot and ankle trauma and reconstruction, and we're pleased to have him on the faculty as well. And then MaCalus Hogan, again from UPMC, University of Pittsburgh, Pennsylvania. Since 2018, he's had a significant experience in his young career with the athletic navicular issues, especially ballet. And we're happy to have him here. He did his foot and ankle fellowship at HSS in New York City. So, and then Loretta Chou, way on the West Coast of the United States today, from Stanford, and she has been the chief of foot and ankle. The ankle service there is an expert in trauma and reconstruction as well, and she's going to be joining us. So again, we're going to have a great hour of case presentations. We want this to be interactive. Again, we'll ask for questions from the audience, and we'll try to answer those as they come in. Anyway, Alan, you want to take over and share your screen and begin your presentation, please?
Yep, sure. Let me share my screen. Okay. Slideshow. Okay, all right. Thanks, Selene and the Parekh Family Foundation for this awesome opportunity to exchange and learn globally again. So I'm Alan again from Pittsburgh, and Selene is truly amazing and inspirational as always. And let me start and kick off this session with some basic information key to acute navicular fracture understanding and some recent adoption of the innovation technology in orthopedic care. So we were talking about that little boat in your foot. So this is my disclosure. It's not related to this topic. So I start off this case, and this is a 36-year-old female with a bicycle injury. As always, those patients come in and they most of the time they do not remember what the mechanism is until you happen to video recording what happened. But usually it's a dorsiflexion or a plantar flexion with some kind of a twist. And that patient, this is the traditional way of evaluating what's going on. And we have a plain x-rays, and we have those suspicious. And the problem is the plain x-ray is not always tell you much of a detail, and we almost always getting the, not almost always, it's a routine. We get our CT scan and different cuts here, sagittal, coronal, and axial. So you look at this, it has some feature of actually the body of a navicular fracture of both the type 2 or a type 3, and also a possible some combination of the injury that we know that happens in navicular fracture. So I will get into that detail a little bit later on after we delve into some of the key feature of the navicular and what's going on and what we should watch out for fracture fixation. And this is the external view as what I fixed the fixation of this young lady. And with the internal fixation combination with external fixation, there are many other ways to do it. The bridge plating is another way. Also, sometimes we would call it internal, external fixator. Each has pros and cons. And unfortunately, we do not have a very high evidence level of support to guide us to do one over the other. So the approach and the pitfalls, we will take a look at it. And the most important thing is we need to restore the length of the columns. So either the medial column or the lateral column. And alignment is really important. Stability and motion, we have to consider the balance of it. So that's why the situation and consideration of you using external fixator, you can take it off a little bit earlier as you wish, and versus internal, external fixator, which you pretty much you need to open it again for another major surgery. So take a look at this boat and piriform shape of the bone in your foot, and this sustains for stability, alignment, and mobility. So you look at some salient features of your navicular. It stays in your medial column as a keystone, and versus to a lateral column in your cuboid. So those two actually you have to check very carefully. They could have injury at the same time. So the other things is interesting phenomenon, we call this zigzag alignment. So your navicular, so your talus, actually the talar head and neck start off medially, and then you ended up with distally your metatarsal straight or a little bit corrected into lateral. So your navicular is acting as a zigzag leadership or flagship direction for the midfoot tarsal bones. So you look at the axis is not transverse, but it's a little bit oblique. It's fitting into a contour of a negative 45 degree of the head of the talus. So, and also the posterior, this is the posterior facet of your navicular, that's 80% of hindfoot motion. So this is very important. And also conversely, in the anterior facet, you have 3 different facets converging plantarly, and it's more rigid. So this has a meaning when you're fixing this type of fracture. Alex Younger has a technique tip that he mentioned yesterday, and also in his paper, and he fixed it with a bridging plate or fusion with the navicular to the anterior tarsal bones, the cuneiform. So this is more stable side while you try to keep the mobility function on the posterior facet. So this is also an interesting paper from 2020. You seldomly see the foot and ankle papers on Nature, those type of publications, but this one is from Yale Lab, and it's a 40% chance of increased stability in transverse arches versus longitudinal arch, as we always looking at. So this is interesting aspect. And also paranavicular structures is really strategic. And we look at is the structure called acetabulum pedis, and you have the superior medial, inferior plantar, and the lateral, your bifurcation ligament, and holding into has a hammock of the talar head, and the navicular is a big portion of it. So the I would say most important thing you have to say it 3 times. So the blood supply is the major issue as we look at this. And this is the classical picture from Torque, and this is probably Safarian's labs, and showing that central of the navicular is a void of that blood supply. This is always the concern. And later, Dr. Nunley is going to delve into the chronic situation, stress fracture especially. But however, in the acute anatomies, you need to consider that also. So you look at the poles, the medial pole and lateral pole, you have enough blood supply. However, the entrance of the center area is much less, and especially when the patient is aging and getting older, and that dramatically decrease. You take that into consideration when you're fixing it. So the blood vessel, we need to take care of the approaches, DPA, MPA, and the plantarly to the tuberosity, and it's very poor in the centrally, and especially in elder patients. So you do not want to create a dead bone sandwich. And when you do in the doing your approaches, And there's a question and when and what to operate in the acute stages and best exposure fixation. So if you want to expose more to put your plate, you can get a very perfect, beautiful X-rays. However, you destroyed all the malleus for the bone to grow, and then you ended up with an AVN. So key to success are length, alignment, and early motion, if you can, to the posterior facet. So indirect reduction, if we can, biological fixation, we need to watchful and careful approaches for those type of patients. So what are we dealing with right now? So this is the oldie but goodie, and I talked to Dr. St. Georgian for one of the patient, and I told my patient, I'm gonna ask the surgeon who devised that classification to ask him what to do. And this is what we're looking at, the acute fracture, and we have avulsion dorsal type, and we have a body with a lateral column or either a medial column, but sometimes it's a mixture, as we show you, as I show you in the beginning that cases, she does have medial column shortening and extrusion at the same time, a combination of the lateral column with the cuboid fracture. So I will show you what the technology, we can figure that out without too much of a struggling. So operate or not operate. So whether it's reconstructible and when we need to give up and do the fusion. So this is still questionable. So column lengthening is really important. So tough cases for many reasons for those kind of fracture. Small real estate for putting your, and also the approaches to try to approach it. So there are other ways to devise, the people have devised that there are ways of doing circle arch, or if you can, put the percutaneous screw, and that if you can get it nice and squarely, that's perfect. So it's a complex shape. You need to know the personality and the persona of the fracture. So and limited blood supply is always a problem. So those are the published different ways of fixing it, and you can choose whatever fits. Now, the problem is the goodie and oldie and the goodies we always use. However, always a surprise, and there's a brain twist sometimes, even for the most experienced surgeons. You always see some surprises when you open it up. Oh, wow, I do not see that shape as kind of like that. I give you an illustration of this. So, but fortunately, we got some new toys now. So the new toys, we are just scratching the surface. Since Chuck Hall started in 1980s, we have a 3D printer. So the 3D printers can give you, this is starting just to scratch the surface. And it's getting much cheaper with the technology has been applied in orthopedics. The publication has really exponentially increased in recent years. So what we can do is affordable. It's probably, I would say, it's a game changer for the future. So either we do it additively or subtractively, and you're using basic models to most of the complex. You can do a biocompatible implants or even bioprinting in the future. So the desktop 3D printer, this is what we use. Usually right now it's FDM SLA. So use your CT or MRI. Usually what I use in fracture care is get a CT to my lab, and they turn it into a STL file, and you get it out of the 3D printing for you. And 3D slides are free open software. This is online. And also we have a communication platform globally for people doing those research from NIH. And this is the basic flow of that. And you get that model, and you can do different coloring. And this is Sam Adams' lab. He's moving a little bit more forwardly and getting those implanted bio or even bioprinting. So we are just scratching its surface. Back to that cases, we had that 34-year-old bicycle injury. From looking at even at a CT, you do not really appreciate the whole extent and what the persona of the fracture. Now we are much clearer. It's tangible, and you look at the pieces. And look at pieces, some extruding on the medial column, and right in the middle has another fragment. And on your letter, the green color is your cuboid. So your cuboid is to show you exactly what it is and directly visual appreciation. And this is what I did as a plan. And so I planned it out. And there is no way that I can put a screw in it, but I would struggle. I would try to fixing it. So make the foot look like a foot, as Dr. Nunley always taught me before. So the mini frag planting, dual approaches, X-fix for columns, and bone grafting if you need it. So you could do bridge plating for those cases. However, bridge plating, you limited your options for motion, especially your TN joint. So if I can, the patient is compliant, I will probably choose those small external fixator fragment. So the follow-up of this patient right now, it's over a half year or 1 year. She's doing reasonably good, walking without too much of difficulties. However, this patient, I will watch out for AVN in the future and also possible fusion, which is do not have a very good outcome for this type of injury. Another case, I would make a decision whether I need to operate or not, just by looking at the x-ray. This is a little bit bigger than a avulsion fracture. So whether that's a type 1 body fracture or not, I do not know. And also, this is from just a CT scan. It looks like possible this is like a type 1 or a type 2 stress fracture. However, the history is important. This guy has acute injury. So I'm dealing with a different animal right here. Surgical decision, if I can put a squeeze in with that large pieces, that's probably desirable. And then I have my tools here. I made it, this one, I had a little bit short notice, so I do not have much of a time to make using the basic material that I usually use in colorization. So I just using that resin and make that. And surprisingly, what you see, there is another piece of fracture, as you can see from here. And instead of using tangible, I can look at it in the computer screen, and this is serve the same purpose and colorize the different pieces. And that piece is really kind of small for me to put a percutaneous screw. And the displacement is somewhat acceptable. So I decided not to operate on this patient and put it in a cast. So this patient, that helped me to make that decision. So, your patient loves you as you show them the model. I usually gave them the model after it's all done, and they think you're a cool guy, cool surgeon, and it's accuracy in reduction planning approach that does reduce my OR time and reduce the radiation time a lot. And I would say the future is here and future is now, and we are only scratched the surface of the new technology here. Thank you very much. This is prayer of world peace, and thanks.
Thank you, Alan. Wonderful technology there. My question would be, it seems fairly specific to a certain amount of equipment and software and so forth. How available is this? Is it just in your center that you have this, or is it multiple centers across the U.S. that have access to this kind of technology?
I believe right now it's from the very beginning in 1980s. So we need like some heavy equipment and more expensive. Now you have 3D printers is readily available, and this is one of my radiology lab. I work with the technology and doing research. So for me, I just take me a phone call and send them a notice a couple of days before, and we have it.
But I'll certainly get a CT scan with these cases, and I think with a CD, especially if you have reconstructions available to you, 3D reconstructions of that, I think it's the 3D model that you can rotate around on your screen. I think that's been pretty helpful for me to try to figure out where the main fractures are that you need to fix.
Yes.
What about the other faculty? I know Loretta, you've got a case, and we'll probably pull your case up here in just a minute if you want to share your screen. But Mac or Loretta or Jim, are you using any of this kind of technology? Or what's your best approach to these comminuted fractures? Do you look for the major fragments and then try to get those together, then try to internally reduce and fix the smaller fragments as well? Or how do you approach these? Jim?
Well, Bryan, you ask awfully tough questions, as you usually do. So the more comminuted the fracture, the less likely I am to put a dorsal plate on because of the blood supply, and the more likely I am to sacrifice motion by bridging. So I think that an open attempt, putting a bridge plate or distractor across and then bridge plating and tapping the pieces into place is more likely what I'll do with these very highly comminuted fractures.
Do you need special kind of plates or screws for the navicular body itself, or just use the distraction?
Just use the distraction. Just use the distraction.
Okay, Mac, what about you?
So, I mean, obviously, Alan and I are at the same institution, and so we do have that benefit of being at an academic center and right down the street, quite frankly, from CMU in a big engineering space. So I use the 3D printing as well. Alan has definitely brought me into that fold. And I also will use CT with 3D reconstructions, as you mentioned. If it is highly comminuted, I will go in, I mentioned this briefly in my talk, I will go in with all the options available, small, low profile, cannulated, as well as solid screws, and also having the mesh plate options available, which I believe one of the cases Alan showed, utilize a mesh plate, and bridge across it and tap in and pray. And also in some scenarios, I will watch it and essentially say, okay, if they fail and still have pain, then I would treat them with a fusion at a later time. And while that population does not do as well as the arthritic population.
Alan, when do you take off your external fixator after you've done your surgery? When do you feel like you're safe, and how do you evaluate whether or not there's been adequate healing to allow pressure on that repaired navicular?
I do not think there is any like concrete evidence to guide me to do so. So usually if I do kind of a bridge plating internal fixator, I tend to take it off around 6 weeks. Well, the X-fix is probably around 4 weeks, the minimum, to 6 weeks.
All right, Jim, you're opposed to any kind of internal fixation. So when do you take your external fixator off?
Same time, about 6 weeks.
Okay. And you just start some gentle motion at that time, or do you start weight bearing at that time?
No, I put them in a cam boot, start some general motion, don't allow any weight bearing for 3 months, another 6 weeks.
Okay, Mac, any difference there? Are you a 6 week guy yourself?
I will let them start partial weight bearing based on their size at 6 weeks in a cam boot with a medial column support based on what I appreciate with healing. But again, some of those individuals are not full weight bearing out of the boot until 3 months, as Dr. Nunley alluded to.
Okay. Mac, if you have a navicular acute fracture case, once you pull that up on your screen, then we'll have Loretta go ahead and present her case here. Loretta?
Yeah, please. Yeah, I'll go next after that. Thank you.
Okay, thank you.
Thank you, Bryan. I have a case of a navicular fracture. This is a 21-year-old active college student who fell downstairs at college, and he presented with a very comminuted sublux fracture. And he came in with the CT scan, and we can see that it's very comminuted. It's totally subluxed, and it was tenting the skin up somewhat, but not that critical. He still had good blood supply. We were able to get a 3D reconstruction. I like to get that, as Jim and Mac said, because I want to understand how comminuted it is, and the more information preoperatively, the better for me. And I went in with all the tools in the toolbox for internal fixation, external fixation, for bridge plating. And this is what we ended up doing. The comminuted fragments were too small, and we didn't feel that we could get good fixation, even with the dorsal fragment, because there wasn't a lot of bone to screw into, and we ended up bridge plating. I usually try not to go into the talus, but in this case, I didn't feel like I had a choice. And I'm leaving this on until there's enough healing. He has CT's coming up next week. And once that shows enough healing, then I plan to remove this.
So Loretta, I'm sorry to interrupt, but when do you get the CT scan in this process? Is it at 6 weeks or 8 or?
I'm actually doing it a little later than 8 weeks. I know he's young and healthy, and I expect that he will heal faster than someone older, but there was so much bone dust and comminution in there, and I've seen people collapse. So I'm just, based on my experience, I'm going a little more cautiously.
Okay, so when you get your CT scan, sometimes the CTs can lag behind the clinical healing a bit, but how do you know for sure when it's safe to take that plate off? Is it just kind of a gestalt that you have, given the patient's age and ability to heal and comminution? What are your kind of your decision points there?
That's true. I don't think it's an exact science. It's just based on experience, what I see intraoperatively, who he is. He's very young and healthy, active, good bone. So I think that I just want to get an idea, is there healing, how much healing, what the percentage is, and put all that together, and I'll probably remove it very soon.
Okay, so when you say whatever you feel comfortable with, you have any kind of objective guidelines, like a 50% connection between the main fragments of trabecular bone or spot welding, or what? Any guidance you can give us with that?
I think all of the above. I like percentages. I think 50% or around there, and some trabecular bridging. And if there's spot welding, how much is it? And is it through the structural part of the navicular?
Okay. So would you be more concerned about lateral comminution and slow healing, or more medial side? What do you feel is the significant side to be healed and solid before you take the plate out?
Yes, more of his comminution was lateral. So I will check on that area more carefully.
Okay. Okay, so you have your CT scan, and you decide it was time to take the plate off, then what?
Then I'll put him in a boot and start him with getting motion going and some weight bearing.
At about 3 months, like everybody else, or
Yes.
are you a
Yes.
conformist?
It's closer to 3 months. About 10 weeks, 3 months.
Okay. So we talked about external fixation versus internal fixation with this bridge plate. I mean, is this kind of your go-to bridge plate technique, or is it, do you ever use external fixators, and why the plate?
I do use external fixators, and I did have the external fixator in the room. I had the bridge plating, internal fixation, all the options in the room. And for him, the external fixator would go into the cuneiform, the talus, and possibly into the metatarsal. And he's going back to college in Colorado, so that's a couple states away from me. And I thought, well, I would feel better if he went with internal fixation. And I also felt that I was able to get more of a anatomic reduction with the bridge plating. That is why I chose the method I did.
It seems to me, I tend to follow Jim's approach to these fractures, where I try to avoid internal fixation. Maybe one interfragmentary screw if you have two large fragments that are amenable to fixation, but I don't want to drill into that already fractured navicular more times than I have to, because I don't want to cause any more reason for a blood supply disruption. So I like these bridging techniques. Sometimes we can push those pieces back in a good position, but again, I'm not afraid to use one small screw from one large fragment to another to give a bit more stability. So Mac, can you, why don't you share your screen with Mac, Loretta, and then you can show his case of acute fracture.
Great. Yeah, I'm going to share my screen now. Just a few quick cases. All right.
We'll probably have time for about one case, Mac, probably.
Okay, great. No problem. Share screen. Great. You guys are able to see my screen?
Yes. Just go to large screen. Yep. Great.
Excellent. All right, great. So as Bryan mentioned, I've been here at UPMC since 2013, and lucky to have Alan as a partner and Dr. Nunley sharing him with us. So I'm going to go straight to, I'm going to skip over the sports case because this is a trauma case here. So 34-year-old female, status post high speed motor vehicle collision, had a left navicular body fracture, left foot pain, swelling, really no concern for compartment syndrome, nerve vastly intact. We had a very interesting fracture configuration, which hopefully will show through here. You guys are not seeing an image there, are you? Just a blank screen? Let's see.
Correct.
Well, there was supposed to be a CT video, but this image actually speaks to the intra-op. So if you really look at this, I mean, it falls along the St. Georgian classification somewhat, but a number of us have seen this, where it shows just, young patient, hard bone. In this scenario, she did not comminude, but has this very defined horizontal fracture here directly through the body of the navicular. Just to kind of move through, Bryan, do you want to ask what people would do with this? Or you want me just to jump to what I did?
Yeah, Jim, would you open this up and put a plate on there or screws, or what would you do?
I'd fix it with screws. I'd fix it with 1 or 2 screws.
From dorsal to plantar?
Yeah, absolutely.
Would you open it or do it percutaneously?
Open.
Why?
We'll get into that in my presentation.
Okay.
And I apologize for not having that CT, but it does show very little comminution. This is not one of those trick ones where, it's 18 pieces hiding on the x-ray. So the CT would have shown pretty solid, pretty big pieces. Please go ahead.
Okay, Loretta, how would you approach it?
I would try and do 2 screws and do it percutaneously with this good reduction.
Okay.
What did you do, Mac?
Yeah, so I took both approaches, but I will say mini open in the middle, but I did 2 percutaneous screws, compressed this, and 1 anterior medial, 1 anterior lateral. And I wanted to be able to see the reduction. And that's one of the reasons I did open it. So I didn't make a large exposure, but I did open it. And so this individual, fortunately enough, did relatively well. However, I did my post-op. I have them go non-weight bearing time 6 weeks. I put everyone in a splint for 2 weeks and then into a cam boot, allow some motion, but non-weight bearing, particularly if this was a relatively reliable patient. I then permitted partial weight bearing with a medial column support from around 6 weeks until 10 weeks. And then I transitioned them into a firm shoe, sometimes whatever type of medial column support they can manage. She was relatively young and healthy, and I allowed low impact cycling, no spinning. And then she was able to get back to light jogging and heavier workouts between 3.5 and 4 months. So I was fortunate in that case, and I'll go back to the final images, but this was essentially the approach.
Yeah, I think this is a great case, Mac. I mean, it certainly is 180 degrees from what Alan showed, which was basically an exploded navicular. And that's a different scenario there. This is a young patient with just a single transverse fracture. And at least in, I think, all of our hands, these typically do pretty well. And we can advance them a little bit quicker than we can the comminuted ones. But I'm glad you showed this, because it kind of shows the other end of the spectrum and how we should approach these. But again, Alan, with the comminuted fracture that you showed, and Loretta too, I mean, you've probably done dozens of these over your Alan, your career has not been as long as Loretta's, but I'm sure Loretta's seen dozens of these over the years. And yeah, so how do they do those comminuted ones, the ones that are pretty extreme? You need a bridge plate or span them with an external fixator. What's your sense of how they do? Is it a partial AVN or no AVN, or arthritis, no arthritis? What happens?
They have arthritis and a lot of stiffness. Patients complain of chronic pain and stiffness. I must say that all the ones I've done, I don't think I've ever had to take anyone back to the OR for a fusion. I don't know why that is. Either they disappear or they're doing enough and living with the stiffness and the pain. You get them into an arch support. I really think that helps with midfoot arthritis.
Alan?
Yes, I agree with my limited experiences. Those patients come up with a lot of stiffness. But I want to add it to the one comment on the approaches. So with that 3D printing models, I can limit my approaches more accurately and where to put my screws, and right on the computer screen and while playing with that model. So instead of open really big and comparing to other tarsal bones, like I've fixed my calcaneus fractures almost always, 90% of the time I do not need to open it up. So because with those models, I know exactly where to go, and my even if with the open approaches will be very small.
Jim, I know all your comminuted fractures do well, but any tips or tricks for us mortals that we can use to keep these patients doing well long term?
Well, I don't know that they all do well, but I agree with Loretta. I can't even think of a case that I've come back on with an acute navicular fracture that required an arthrodesis. And maybe they went elsewhere, but I agree. I think they probably just live with the stiffness because, of course, they get their dorsiflexion, plantar flexion through the ankle. So,
no, I think they probably adapt to it. It's a stiffer first ray, but they learn to modify to reduce pain and improve function. So, Mac, any words of wisdom? How do you keep these patients out of trouble? These post-traumatic ones.
So I think to the points made, a lot of education when they have it. I mean, a lot of us, I know we spend more time talking patients out of surgery, but when they need surgery, I try to warn them of what's to come, right? They may have some component of chronic swelling, the stiffness, and a feeling of, and trying to describe that, a feeling of tightness, but also reassuring them that, hey, if this all goes well, they will be able to get back to a functioning and fulfilled life and can be active, but they will need to use, stiffer shoes, modify their approach with certain activities, and just try to overeducate so that they are in a better position to, as Dr. Chou and Nunley had mentioned, they kind of function with it going forward, right? And I think that's very important. The education, just laying it on thick that you have a problem. This is a very challenging joint and a challenging bone, and we'll do the best for you. So that's all I really have done up to now. And for 9.5 years, that's boded me well. But that is not as, I'm sure there are some stiff hindfoots floating around as a result of something I've done to them. No question about it.
Well, it's a great session on acute navicular fractures, and I think we're going to move now to the stress-related fracture in the athlete. And I can't think of anybody more qualified to do this than Dr. Nunley. So, Jim, you want to pull up your slides here and do your talk?
yes, let me go to the top. Okay, so why is the navicular susceptible to stress fractures? And I think there are two real good reasons for it. A lot of people actually consider this a CAM lesion, as we'll talk about, but vascular anatomy is very important. You saw this slide from Alan. It's from Torg's work back in 1982, where he talked about dorsally the blood supply comes from the medial tarsal branches of the dorsalis pedis. Plantarly, it comes from the medial plantar artery, medial from the anastomosis of the dorsalis pedis and the medial plantar, and he describes the central third as relatively avascular. Well, that was pretty good in 1982, but that doesn't turn out to be exactly accurate. So Sandy Klein and Jeff Johnson at WashU decided to investigate to see if in fact that was correct. And they did a much more extensive study where they looked at the intraosseous anatomy of the navicular, 60 legs, 30 cadavers, the classic India ink and latex with the Spatzer-Holtz technique that we've used as well. And lo and behold, only 12% of the specimens had this avascular central zone. So that gives us pause to think about why certain athletes get the stress fractures and then they get them again, and other people get their stress fracture taken care of, and they never have any further problem. And it may well be that these people are the ones that are in the 12% that have the poor blood supply, and that's the reason why they have more problems with non-unions, AVNs, and refractures. Second reason is when we think about the mechanics. During heel strike, the navicular is compressed between the talus and the cuneiforms. And the force is mostly centralized over the center. Additionally, contraction of the posterior tibial tendon increases that medial stress. So most of the force is exerted on the central third of the bone. And that's why I think in the acute fractures, you need to use an external fixator in those comminuted ones, because with a bridge plate, you can still get contraction of the posterior tibial tendon, and you can get some displacement. So be that as it may, when we think about it, we have the body weight here from the head of the talus, we have compressive forces between the cuneiforms and metatarsals, and then we superimpose the 12% of the people who have poor blood supply, and you have good reason for these to fracture. And as I said, a lot of people believe that this is a CAM lesion for that reason. So what are some of the associated factors? Well, they certainly don't cause it, but they have been highly demonstrated to be present. So a short first metatarsal with a long second metatarsal or metatarsus adductus, flat foot deformity, limited subtalar motion, and then preoperatively, pre-injury medial narrowing of the talar navicular joint with reduced ankle dorsiflexion. The athletes who get this are usually involved in some type of running, jumping, and cutting where they have explosive movements. And then don't ever forget poor nutrition. So I harp on this because I use calcium and vitamin D on every single patient that I operate on and have for over 10 years. 70% of the US population is vitamin D deficient. And so if you don't get 20 minutes of natural sunlight a day, you don't convert vitamin D into the active form. Every patient I operate on gets 50,000 units of vitamin D preoperatively and every week preoperatively, and for 3 months postoperatively, and 1,000 milligrams of calcium. And I think this is one of the things, along with hormones, that's not well looked at with navicular stress fractures. So also excessive training can result in chronic muscle fatigue, which then can lead to the resulting stress fractures. So when we think about it, I am not an advocate of a TORG, and we have recently published our literature. I think he's absolutely incorrect when he says 100% of these will heal with 6 weeks of non-weight bearing. That study is totally fallible. If you look at that JBJS article, it came from 14 institutions, only 10 patients were treated that way, and they had no follow-up CT scans to show that they were healed. So in my practice, a stress fracture is going to be treated with some type of a surgical procedure in these athletes. So some people advocate percutaneous fixation with the screw placed from lateral to medial. And the reason that you do that is that there's more bone medially, so you want to have the threads on the medial side. Others have advocated open reduction, internal fixation, and when there is cyst or other problems, using autologous bone graft. And then I've popularized the use of a vascularized bone pedicle, especially in patients that have had previous attempts and had non-union or have sclerosis or AVN. So we just recently published this paper on my experience with navicular stress fractures, and I divide them into 3 different groups: acute fractures, stress fractures that are less than 3 months. Chronic are those that have gone on for more than 3 months, and in those, I tend to open the fracture more extensively and to use iliac crest bone graft. And in those that have had a chronic fracture, sclerosis, AVN, or previous, then I utilize this vascularized bone graft that we published in JBJS in 2004. So a lot of people shake their heads about this. This is a procedure that any foot and ankle surgeon can do with some loops. You can get your blood supply from the first cuneiform or the second. It's a blood vessel that comes off the dorsalis pedis, and this is your exposure anyway to the navicular through a dorsal incision. And as you can see, I'm demonstrating here the exposure. This is where the non-union is. This is the vascular pedicle, and it's got an artery and 2 veins in it. It's about 5 millimeters wide and about 1 centimeter in length, and it'll drop directly into this non-union, which we've taken down. You can see it being rotated here on this vascular pedicle and tapped into place, brought right in. So what are we doing here? We're recreating vascular blood supply, which is, we know that this bone has poor blood supply. So look at the 40 cases that I've done over the last few years. 15 of them were acute and had ORAF. 12 of them had bone graft. And then it's actually now 17 in the paper that had vascularized bone grafts. And you can see the distribution right there. So everyone had good follow-up, at least 24 months. And just like published in other series, Bob Anderson and others, about 80% of those with ORIF or bone graft healed. And we were lucky. We got 100% to heal with the vascularized bone graft. I have to say that 2 of those patients then went on to have enough arthritis that they went ahead and actually had an arthrodesis done. So I think that, at least for me, this is an algorithm of how I like to approach navicular stress fractures, especially in patients that are sent to me that have had previous surgery and have more advanced radiographic findings.
Great, Jim. Nice presentation, both on blood supply, obviously very important issue with these type of patients, and a good update on the literature as well. Do you want to show us some cases, Jim, of your stress fracture patients?
That would just be great. Let me see. How do I get to? I need to be able to get back to my regular screen. So hold on just a second.
Your share screen and then...
Yeah, but okay. So Bryan, I can't seem to get back onto the share screen when I do this.
Look at the bottom central part of the green tab. It says share screen.
Yeah, but unfortunately, I'm now off of that. Let me
Hey,
see.
Jim, can you help out with that? Stage manager, Jim.
Yeah. Can somebody help me with this, please?
Mac, do you have
Bryan.
a case with, while we're waiting for Jim to kind of pull this together, Mac, do you have you had a stress fracture case, didn't you? You're on mute, Mac.
I had this injury in an athlete that's actually a very interesting one to look at, which I'm happy to pull up in the interim.
Yes, go ahead and pull that up. Okay.
Yeah, no problem. Do it right now. Interesting. Now my screen froze. Oh, here we go. All right, I'll pull this up. And just let me know when to pull down. Let's see here. So 27-year-old male hockey player with a direct puck to skate, had left foot pain, inability to skate due to pain, otherwise neurovascularly intact. And then upon the scanning, had this fracture really along the medial navicular, not in the standard stress fracture region, and also has this concomitant accessory navicular, which is likely, with these professional hockey players, many of them have been skating and aggressively everting since well before, since 5 or 6 years old. This was quite interesting and how we really thought through our approach with this particular player. So happy to hear thoughts from others on this before diving in on it.
Mac, is this the only CT image that you have? Is it basically just a medial prominence fracture?
Yes,
there?
it's more of a medial tuberosity, medial prominence.
Not your typical stress related.
No, not as typical
fracture.
stress. Not a typical stress fracture, which is why I kind of just threw it in there as a interesting add-on. I have a stress fracture too on another player, which I can pull up in a moment. But was curious thoughts on this from the group.
Okay, Loretta, any insight as to how you'd approach this? So it looks like close to the insertion of the posterior tib, but how would you treat this?
Yes, and how long has he had symptoms, or how long ago was the injury?
The injury. So the injury was acute. He took a puck to his skate in the middle of a period, and then could not skate after that, which is also pretty rare to take a pretty hard hit like that. But his posterior tibial tendon function was intact. Was definitely able to still invert, but just too painful to actually skate on this.
And he needs to get back on the ice tomorrow, right? Yeah.
Well, luckily he himself could not skate, and so he helped he helped the sports foot and ankle surgeon out on that one. He helped everyone out. He couldn't skate on it.
Loretta?
With a competitive skater, I'd be aggressive and percutaneously put a screw across.
What would you tell them about, or her, because there's, at least in Minnesota, there's a lot of female hockey players
Mhm.
in Minnesota. So what would you tell this player about return to play?
I think there's a great chance of return to play. I would like some healing and decrease some symptoms. So about 6 weeks, at least 6 weeks.
Absolutely.
Is that what you said?
So in this particular case, so I wanted to be aggressive with this one. But we did take the consensus approach in treating them non-op. Because we have our partnership with our sports physicians, and I said, if there's a lack of ability to advance, we need to put a screw across this. And now we are risking retraction or essentially dysfunction of the posterior tibial tendon in some capacity, which is a much bigger deal if that comes up later. So we treated this individual non-op, non-weight bearing for 4 weeks. We actually gave him a bone stem, medial column support, then allow him to walk in the boot at 4 weeks. This player also was pretty tough and really wanted to try to tough this out and was able to actually recover and return to hockey and play at 6 weeks. But I will tell you, and we also got him a custom arch support for his skate to try to build up his medial column a little bit more to not put strain on this. And I also used the approach that Dr. Nunley mentioned, which I failed to put in the slides, very high dose vitamin D and calcium during that conservative treatment window, and they healed. And so we have not repeated the CT scan of yet. This is quite fresh of an injury. We'll see how it goes.
Doing well.
He's doing well.
Okay.
I'm holding my breath.
Jim, are you back in action there?
I am. Yes, I am.
Okay. I'll
sort of more of a
stop
traditional stress related fracture and see what Jim can impart with it to us about tips and tricks of how to approach these. You got one that's maybe a partial fracture and then one that's complete. We just got about 8 minutes here, Jim.
So what happened here, I'm seeing it, but I don't think you are you?
Not yet.
So I don't understand. It was, what happened to the stop share that, share screen. Here we go. Okay.
There we go.
Okay. So this is the reason why you don't do percutaneous screws. So this is a 27-year-old professional basketball player. And actually, when she was at Duke as an undergraduate, I fixed her right navicular in 1996. She went on to become an All-American and played in the WNBA. So in May of 2004, she got the opposite side, a left navicular stress fracture, type 1, treated non-operatively with immobilization for 6 weeks, but continued to have pain. So after 6 weeks, the decision was made that this would be a good candidate for percutaneous fixation, and this was done at an outside facility with that 4.0 partially threaded screw. And she was treated non-weight bearing, but no immobilization. And she was sitting on the bench of the team and was told to dorsiflexion, plantar flex her ankle. When all of a sudden, oh my God, she felt this incredible pop while sitting on the bench, and then she couldn't dorsiflex her foot. MRI showed that she had a complete rupture of the anterior tibial tendon. Here's her postoperative x-rays. Oh my goodness. So I'm operating on her. There's the tip of the screw. There is the tip of the screw.
So clearly, Jim,
there's the ruptured anterior tibial tendon. So if you're going to do percutaneous fixation, number one, you have to understand the anatomy, which was very clearly outlined. Number two, the best technique is to use intraoperative CT to guide your screw fixation. So in any event, this was a catastrophic, but fortunately, I was able to go ahead and repair it. I repeated her fixation. There's her CT scan 3 months later, completely healed. And she actually went back to have a good career in the NBA. So I don't like percutaneous fixation where there's danger. I think that we could all have this happen because you know the shape of the navicular, and the tendency is to have it too close to the dorsal cortex. And so for me, it's always safer to make a small incision. You can see blood vessels. You don't have to destroy them to go in there, and you can do your surgery.
I think it's a great case, Jim. And I think the take home point for me is you got to, you look at that initial x-ray, and it was clearly that screw was too horizontal. It didn't go plantar medial from the dorsolateral approach. And you definitely have to make sure that the tip of that screw is not too far through the cortex of the navicular. If it's too dorsal, like we just saw, it can rupture the anterior tibial tendon. If it's too through the cortex on the posterior medial side, it can rupture the posterior tib. So again, a good case to show that's the proper technique is go dorsal lateral to plantar medial, and whether or not you open it up and look at it just depends on your comfort level with this. I find that intraoperative fluoro is pretty good at predicting whether or not you penetrated that medial cortex. So I don't necessarily get an intraoperative CT for that. I don't have the technology for that, not like Duke University has, but I think most of us who have a good fluoro machine can probably predict, where the tip of that screw is going to be.
I don't have time to show this other case, but I would like to describe it because it's a current NBA basketball player, similar scenario, had one side fixed, did well, second side fixed, and we have a CT scan completely healed. So then he goes to his dermatologist to be treated for the fact that he can't grow any hair. And he comes back 3 months later, and the CT scan shows AVN, and the whole navicular is crumbling. So we asked him, well, have you been using any steroids or prednisone? And he said, is prednisone a steroid? And we say, yes. We said, that's what I've been rubbing on my head for the last 3 months. So my point is that even with a healed navicular, you can have a problem in patients if they're taking prednisone for asthma, for anything else. It can be devastating.
Jim, how do you rehab your stress fracture patients? Say it's an incomplete fracture. You say you're pretty aggressive about getting internal fixation, even with the non-complete fractures, and
Yes. And everybody.
So how do you treat them post-operatively? Say it's an incomplete one, you put a screw or two in there. What else besides the nutrition that you talked about? Electrical stim, maybe. What else?
Every one of them gets electrical stimulation and ultrasonic stimulation. Ultrasonic 20 minutes a day, electrical 8 minutes at night. They're all put into a cam boot so that they can start range of motion. And then I let them go ahead, and once the wound is healed, get into the tanks where they're non-weight bearing so that they can go ahead and start their range of motion.
Okay, so
looks like we're out of time.
When do you start weight bearing? Any of the faculty members? Because we all treat these. You let us start
not until between 6 and 8 weeks.
I get very nervous with that one. I would say between 8 to 10 for me. I can't weather the complications the way Dr. Nunley can with his storied career.
Loretta, do you get a CT scan after a certain amount of time post-op?
Yes, I like to get a CT scan just to be reassured that there's some healing before I progress the weight bearing.
So I don't get a CT scan until 3 months afterwards, and then I expect to see it healed. But I don't have a problem with getting one at 6 and 12.
All right. Awesome. Great session, guys. Bryan, thanks for moderating, and great insight from all of you. Fantastic. I'm sure everybody got a lot out of it. We're going to take a break for a minute, and we'll be back with the next session. Thanks, guys.
Thanks, everyone.